Thank you both. And now I would like to turn our attention to another panel addressing this time the latest advancements in Medicaid maternal mental health considerations. This is a panel I'm very excited about. I've said that I think before most of the panels, but this one in particular is exciting to me as we're going to hear from one state Medicaid agency who we've talked about yesterday, the Pennsylvania Medicaid agency, whose HEDIS screening scores are at the top of the pack. And we'll get to hear why that might be the case. And it's really the first time we'll see some sort of evidence-based policy and strategies around improving detection and follow-up and treatment for these disorders. Moderating this panel is is Maggie Clark, a former journalist. We like journalists around here who unpack the complexities of maternal mental health and share solutions. And it's safe to say Maggie's also a policy wonk with previous experience working at the Georgetown Center for Children and Families, who we're going to hear from on our panel as well. She currently works for the Riley Group, which is supporting the Postpartum Support International Mind the Gap Coalition. Maggie, I'm thrilled to turn it over to you to moderate this very exciting conversation. Thank you to you and the panel, and I turn it over to you.
Thank you so much, Joy, and to the Policy Center for hosting this forum, bringing us all together for these important conversations around maternal mental health. Thank you to Joy and the Policy Center again for having me, and I'm thrilled to moderate this conversation among powerful leaders leveraging the power and reach of Medicaid to improve maternal mental health and family development. So as we know, one of the key drivers of maternal mortality crisis is untreated perinatal mood and anxiety disorders. And Medicaid, which finances nearly half of all births each year, really has a central role to play in ensuring that moms and caregivers have access to the mental health care they need before, during, and after pregnancy. So our conversation today is going to explore the latest federal and state efforts to leverage Medicaid's tremendous reach to improve perinatal mental health and connect pregnant and postpartum people with the care that they need to thrive. So I am thrilled to introduce you all to some powerful leaders in the space. I'm going to start with our federal partners and then move to our guests and state focus work. So I'm going to ask if Kristen can kick us off with introductions. I'm going to go Kristen, Linda, David, and Elizabeth to introduce yourselves.
Sure. Hi, I'm Kristen Zeikerman. I am the Quality Improvement Technical Director in the Division of Quality and Health Outcomes within the Centers for Medicare and Medicaid Services in the Medicaid area of Medicaid and CHIP. I'm also the lead on the Maternal and Infant Health Initiative. Sorry, just got to put the maternal and infant in there.
I'm glad you added that. I'm Linda Streitfeld. I lead the work at the Center for Medicare and Medicaid Innovation on the Transforming Maternal Health Model, which is our newest initiative. We announced it in December, and Kristen has been part of our team, along with others from CMCS, as we've been developing this model.
Great. And David, please introduce yourself to us.
Hi, I'm David Kelly. I'm the Chief Medical Officer for Pennsylvania Department of Human Services, our Medicaid program, the Office of Medical Assistance Programs. And we provide services to over 3 million individuals and pay for service delivery of probably over 40,000 live births every year within the Medicaid program. So part of my responsibility is really helping to drive not just policy, but operations and quality improvement around maternity care.
That's great. We're thrilled to have you. And Elizabeth?
Hi, I'm Elizabeth Wright-Burak. I'm a research faculty at the Georgetown Center for Children and Families, and we're a mission-driven policy research center with the goal of improving healthcare coverage for low-income children and their families. And so I lead our early childhood and maternal health work, thanks to Maggie for helping us grow it. Thanks for letting me be here.
Great. Thank you, everybody, for introducing yourselves. And you see, we really have the breadth of all the levers that Medicaid has to improve maternal and infant mental health. And so I'm going to start with a question for our federal partners. Kristen, you mentioned at the Center for Medicaid and CHIP Services, where you sit, we're seeing a lot of states, the majority of states adopt and implement the 12 months of postpartum Medicaid coverage. And also, reporting quality metrics for prenatal and postpartum visits. And so I'm wondering if you can share with us, how CMS is thinking about supporting states in implementing this longer postpartum coverage period as we think about pregnancy and postpartum being really, a 2-year process, and how, in that longer coverage period, how that can increase access to maternal mental health care.
Sure. So as you noted, we are up to 45 states plus DC plus the US Virgin Islands in the 12-month extension of postpartum coverage. But we recognize that coverage is just the first piece of the puzzle, and it doesn't necessarily ensure access or high quality care. So that's where we, in the Division of Quality, kind of fit the extra pieces in the puzzle of helping states through quality improvement technical assistance improve their processes for connecting people to the care that they need. So we recently wrapped up our improving postpartum care affinity group. And out of that came some really useful resources. And I think that there, as part of the handouts, there are links to a lot of these resources, including a driver diagram and a change ideas table, a measurement strategy, a getting started in QI video. Additionally, we have recently put out a toolkit for states involving postpartum care, which highlights things such as states can choose to pay pediatricians for screening for maternal mental health, postpartum depression, postpartum anxiety, those sorts of things. And they're able to bill for that and get paid for that. So for the people that are not necessarily coming to their postpartum visit, they're that's a touch point in the health system that we want to capitalize on. Additionally, the prenatal and postpartum appointment rate measurements, as you noted on the core sets, are for the age range that is below 20 are mandatory starting this year in 2024. And we're hoping that if you're already reporting on those under 20, like we do have the majority of states reporting on the adult population as well for those measures. So we hope to continue that trend as well, to be able to track those things.
That's great. Thanks, Kristen. Yeah, the quality metrics are really important, and you bring up a good point about the metrics for postpartum visits in the child core set are mandatory, and the adult optional, but hopefully coming as well. And
but
thanks,
all the
go ahead.
behavioral health metrics on the adult core set are also mandatory.
Mm-hmm.
And additionally, I just have to plug that newly announced, and more information will be forthcoming, but we are planning to launch in May a webinar series, an affinity group that is targeted on maternal mental health and substance use.
Oh, fantastic. Yeah, please do share more about that and links. We would love to see that. Thanks. Linda, I'm going to turn to you now in your work at CMMI. And you mentioned this in your overview, but the transforming maternal health care model really feels like it's building on the foundation that CMCS has set with coverage implementation to kind of test models of maternal care and Medicaid. Can you tell us more about the model, where you are in the process, and what people in this audience, might need to know about how they can be involved and supportive?
Thank you for that. I'm very happy to talk about the transforming maternal health model. It might help to make sure that all of the viewers understand who we are as the Center for Medicare and Medicaid Innovation. We are a small center, part of HHS, that acts as something of a think tank to test ways to improve care and reduce costs for Medicare and Medicaid beneficiaries. So this particular project aims to improve care for pregnant and postpartum people. So this test, which we call a model, is going to support expansion of the very best evidence-based maternity care by giving 2 state Medicaid agencies 2 things: targeted, tailored technical assistance, and this builds on the CMCS work, we're going to be giving them some money. Because one of the things that we've heard is that state Medicaid agencies are always strapped for cash and don't necessarily have the resources to implement the things that we know make the biggest difference. So we're talking about whole person care that makes birthing people feel empowered and safe and healthy throughout the maternity continuum. Specific goals are to reduce disparities in access and treatment, to improve outcomes and experience for mothers and newborns, and to reduce overall program expenditures associated with high morbidity and mortality. Here's how we're going to do it. We're going to select up to 15 states to participate, and we're going to support those states with up to $255 million total. That's $17 million per state across a 10-year test. And that test will be 3 years of pre-implementation, during which we'll be providing all of this technical assistance across a really broad spectrum of evidence-based best practices. And the Medicaid agencies will be partnering with the boots on the ground, so to speak, the managed care entities, the maternal health providers, the hospitals, the community-based organizations, the midwives, the doulas, the perinatal community health workers, et cetera. And all of them will be required to complete certain specific activities during this pre-implementation period. And then they'll be launched on 7 years of implementation, during which we hope to be collecting lots of data to help us understand not just what works, because we already have a good sense of that, but what combination of things work best, and what are the adjuvants or the local circumstances that make things work better, and how does the technical assistance help? And so we'll be looking at all of those things with the goal of being able to expand those best strategies beyond the end of the model. And just quickly, I don't want to take too much time. One of the sort of central pillars that this model is organized around is that whole person delivery care approach. And that's the one I think that is most salient for thinking about maternal mental health. We want to ramp up consistency across the board on things that we know are helpful. So requirements here for participants in the model will be to provide the risk assessment, the referral, the follow-up coverage for perinatal depression, anxiety, tobacco use, substance use disorder, all of that, along with health-related social needs and a big focus on equity. So last thing I'll say is, because the applicants for the model can only be state Medicaid agencies, if you think that your state might be a good candidate for the model, or it's something that would really improve things in your state, I would urge you to take a look at the website. We expect to be issuing that notice of funding opportunity in late spring, and talk to your Medicaid agency and see if it's something that might be feasible to apply.
That's great. Thank you, Linda. And I believe we have the links to all the material in the session packet. And we can get those links in the chat as well. That it's such an exciting opportunity to really see kind of the power of the two, CMCS and then CMMI, coming together and really focusing on this population, because it's, as many of us know, kind of getting the attention of policymakers around maternal health, mental health, it's hard sometimes. So it's really wonderful to see so much attention and investment. And kind of speaking of the state perspective a little bit, state Medicaid agency, David, I'm really excited to turn to you and just, stress what Joy was saying at the top of the conversation about how Pennsylvania really has been a leader in screening and connecting people with perinatal mental health care. And, we hear a lot about the barriers and reimbursement, provider incentives, all of these challenges. How have you in your role as medical officer for Pennsylvania Medicaid kind of looked at these challenges and prioritized perinatal mental health?
Sure. Well, I'll just say that my team over the last decade or more have really been very focused on maternal health, and especially looking at both depression, anxiety, and opiate use disorder, because those are key variables that really drive maternal morbidity and mortality. So we've been really working at this for quite a while. I would say that, again, it's about patients, it's about working with our providers, and it's with, we're a managed care state, so it's working with our managed care plans as well. From a patient standpoint, there are a whole host of things that we do, but that our managed care plans do. But as an agency, I mean, we did open up access. We are one of the states that has the 12-month continuation of coverage, and we're proud of that. Also, many years ago, I think it was mentioned either by Kristen, I think it was Kristen, that we pay for moms getting screened at well-child visits by pediatricians. We've been doing that for a very long time and working with our pediatricians and family medicine colleagues to really make that happen and to make that, set that as a priority. We also have a perinatal quality collaborative, and there's several areas that the quality collaborative focuses on. It's not run by Medicaid, but we stood it up probably 7 or 8 years ago. And the two key focuses initially were opiate use disorder for moms and babies, substance exposed infants. And then we also looked at treating maternal depression. And that treating maternal depression, there's a lot of really intensive activities. And I think we have over 60 large health systems, OB groups that participate in that perinatal quality collaborative, and really got into the nitty gritty of how do you put depression screening into your normal day workflow? What do you do when you screen positive and it's like, wow, what am I supposed to do now as a provider? So that perinatal quality collaborative really worked with those sets of providers to really work this into their workflow. Also, how to code it up from a billing standpoint, from HEDIS, from a quality measurement standpoint, how to bill it, even though in some instances there may not be direct payments for those codes. But there was a lot of activities, and we really set the priority that this is a key component of maternal care. And if we don't address maternal depression, we don't address opiate use disorder, that we're missing a huge opportunity to really improve the lives of our pregnant individuals. We also, for many years, have what's called an OB needs assessment form that our providers, probably about 85% of the time, 85% of our live births, providers have the opportunity to fill out this electronic form that allows it's a basic screener. There are questions, check boxes for depression screening, both prenatally and postpartum, and not just screening, but did you treat? And naming the tool. Was it a valid tool? That's been incorporated into that electronic version. And literally, when providers do that screening, they send that to our managed care organization. So they screen, and if they find a positive, then we're asking them on a later submission. They can submit that up to 3 times, twice during pregnancy and 1 postpartum. But that's really essential, because that then gives our managed care plans, before they get any claims, they get a lot of information. Health-related social needs, but they also get results on depression screening. And they can also work with the providers if they need to make referrals to get pregnant individuals into treatment. So that's one major way that we've worked with our provider community and our MCOs to really drive quality improvement when it comes to depression screening. I would also say that we developed a maternity care bundle payment program. It's really more of a gain share program with our high volume OB practices. Part of that care bundle there are incentives based on, you can get more of your gain share incentive if you are screening and treating both prenatal and postpartum depression. So we've built that into that particular model, and we also build in their screening for health-related social needs. So that's another example of how we've worked with our MCOs, and our providers are working collaboratively to really elaborate on being able to do quality improvement, being able to measure what's happening in maternal depression. And then lastly, I'll say we have our home visiting program that is really evidence informed. We use, this is any Medicaid, any mom that has Medicaid, doesn't have to be high risk, and doesn't have to be first time mom, but they can get home visiting prenatally, and then mom baby actually can have home visitation for up to 18 months postpartum. So that's an opportunity for both licensed and unlicensed individuals like doulas or community health workers to really work with mom prenatally, and then mom and child postpartum. I'll stop there, but those are just some of the things that we've put into place on this, and really trying to improve the quality of care and get folks screened, and not just get them screened, but actually get them into treatment for depression.
Thanks, David. I have a lot of follow-up questions. I'm going to ask one because in the interest of time, I wonder, it was pointed out to me, and we hear this a lot in policy conversations, that one of the things that states want to do is put in a screening mandate, but you all have achieved this without necessarily having a mandate. And so I'm just wondering if you can talk about that. You've laid out, many of the actions that you've taken. But if you can just, reflect on, mandate versus not.
I think we prefer not to do mandates. I think you get more better. I think you get good results if you're working again with pregnant individuals, and you're working with the providers that are delivering the care, and community-based organizations that are also interacting, community health workers or doulas. So I don't really believe in mandates. I think that work in what I've described over a decade or more, that we've been able to really embed this in what's happening within obstetrical practices with our physicians, midwives, and other providers.
Mhm. Well, thanks for that. And really just some excellent state examples. So I'm going to turn to Elizabeth now and ask you more about your report laying out opportunities to leverage Medicaid, and, similar types of examples to what David was sharing, those laying out opportunities to leverage Medicaid for improved maternal and infant mental health as well, particularly in that postpartum coverage period that we talked about. So Elizabeth, what are some of the recommendations that you all put forth for states to ensure that pregnant postpartum people and their infants are connected to care?
Well, thank you, Maggie, for the opportunity to talk about this. I'm so glad I'm going after David, because I feel like I ticked off. You really gave great examples for all of the sort of bucket of recommendations we came up with. And I should just note that, we did this report in part because we knew all but 4 states had been moving to extend postpartum coverage. And we felt like this is the time to make sure we could lay out the steps for what Medicaid can do to get moms and their babies to the right services during this very time-sensitive period of family change. So we actually got together a group of Medicaid leaders and experts. In some states, we got practitioners, OBGYNs and mental health practitioners, and also Joy from the Policy Center participated, just to make sure we had the best ideas of where Medicaid can come in to promote these very kind of practices and best practices we're seeing that are driven in part by community needs, or in full by community needs, but also the needs of families. So, and we really wanted to focus that too on, we know mental health is where these gaps lie. And I think everyone here on this call knows, but I don't think it's not necessarily widely known that, of course, we need to address maternal mental health, just for the mom itself, right? But untreated maternal mental health can also have an adverse effect on early childhood development. So how do we think about this dyad, each of the individual patients, but also that dyad together. So we had 5 buckets of sort of very specific ideas and recommendations, with the idea that states are all very different in how they run their Medicaid programs. And so the exact tactic might be different from state to state. So the first was, let's enhance primary care so it can really be that hub for families. I know we've heard from different practices who house pediatric and OBGYN care and mental health that's integrated. The idea here is, short of increasing rates across the board, how do we incentivize the models or the practices happening in primary care, whether it's the Healthy Steps model for kids that also supports the parents, or the AIM bundles and practices that we've seen. How do we do that? The second was really about this connection piece. How do we monitor and then reward the connections to care? So it's great to have a positive screening. What next? Can we use these HEDIS measures or other places to say who had a positive screen and actually got something as a result? And let's make sure we're measuring and looking at that. And also potentially, paying for the kinds of case management or other services that need to happen. The third was really about services, right? We want to finance the right services and remove unnecessary barriers to those services. So one of the examples we always come up with for young kids' mental health is dyadic treatment or parent-child therapy for young children under age 6. On a survey we did last year, we know at least 8 states reported that they don't reimburse for that service in Medicaid. But beyond dyadic treatments, we also want to make sure, is it important? I think David mentioned some of this. Do we need to, are there some things like maternal depression screening or even treatment for moms that Medicaid needs to reinforce and really look at? It's one thing to have a policy and allow it to be reimbursed, but have we signaled to the providers and community members and the moms themselves that it's available? And the kind of things that David mentioned, in working in partnership with communities and families and providers and plans can help do that. And then removing barriers to services are things like considering things like prior authorization in that very time-sensitive period of early childhood development and maternal health. Is that an additional barrier, or does it actually help moms and babies get the care they need? And states certainly have the ability to remove that. I think there was a panel on extended workforce capacity, but you can imagine Medicaid can't do everything, but there are a lot of things that Medicaid can do, including doulas and community health workers that could target this year. And finally, it's going to come back to David in Pennsylvania. It's really about, in the Medicaid agency, prioritizing mental health for moms and babies, whether that's staff dedicated to this, as we've seen in some states, whether that's making sure you're working with public health agencies or others to work together. And just making sure, whether it's a mental health table that you want to make sure the developmental needs of new moms and babies are represented, or it's a maternal and early childhood health tables that we want to make sure mental health needs are represented. How do we make sure this unique and time-sensitive mental health needs of pregnant and postpartum women are represented? So Medicaid has an incredible leadership role to play, and I'm happy to know that David's doing that in Pennsylvania.
Thanks, Elizabeth. Well, just going around the table, we've got so many great perspectives, and we are running low on our time together. So I'm going to ask everybody just kind of a last reflection question, thinking about our audience of policymakers, payers, practitioners, advocates, what and I'll start with you, Kristen, Linda, David, and Elizabeth. What do you want them to take away about, how to think about Medicaid's role in maternal mental health and ways that they can engage with Medicaid on that?
Well, I can tell you that from a federal Medicaid perspective, like, we very much want to stay involved with the state Medicaid agencies. We want them to utilize the avenues that we have, the TA. Reach out to us if you have questions on how to do things, on if you want to do things differently, if you want to work with your providers, if you want to, if there's other partnerships that we can help facilitate. We really want to help move this work forward as best we can.
Yeah, thanks, Kristen. I would build on what Kristen said by emphasizing the idea of partnerships. Medicaid has certain federally granted authorities, but individual states have the most authority, obviously legislatively. And so much of this work has to happen on the ground in communities with collaboration among hospitals and community-based organizations and providers, and finding ways to make sure everyone can work together in the most efficient way. So that's what I hope people will really be looking for.
Mhm. And David, I'm going to amend the question a little bit for you too, of how can states learn and replicate what you've been doing in Pennsylvania to prioritize maternal mental health and Medicaid?
I'll put a plug in for the CMMI program that Linda talked about, because I think that is a great opportunity, to get the technical assistance and kind of share within a learning network on what can be done that's evidence-based, that really can drive outcomes, and setting up the right infrastructure to being able to measure quality improvement, being able to measure gaps in equity, which is very, very important. I think that really working with our federal partners, that's one great way. The other thing that I know we've done is we've worked across multiple state agencies, including our public health agency, but in our Department of Drug and Alcohol programs. So really working collaboratively with our federal partners, but other agencies, and then obviously being able to really partner up with our providers and make sure that our pregnant individuals are informed and know about the access to the benefits that they have.
Mm-hmm. And Elizabeth, I'm going to give you the last word.
Well, I really think the time is now. We have all this attention we haven't had in a long time on maternal mental health, especially, and we need to keep the pressure on and helping Medicaid agencies and all the partners we've talked about really make the system work well for families. So we appreciate anyone who's trying to help influence those conversations.
That's a perfect way to end. And I'm going to hand it back over to Joy. Thank you all so much for your contributions to the conversation today. We really appreciate it.
Yes, thank you all. Thank you, Maggie. Really exciting to see all the work that CMS and CMMI are doing to advance maternal health and mental health, and of course, maternal mental health. We're grateful and thank you for your leadership. Other panelists, I hope, David, that you're tapped often to provide TA in some of these working sessions to other states. What you're doing is remarkable. We were so excited to lift it up as a best practice. So thank you all. We're going to pop up an opportunity for all of our listeners and participants to share what word or phrase resonated with them in this session. We're going to pop up our Poll Everywhere opportunity. You can go to pollev.com/MMH and enter a keyword or phrase. You can also text, and here we go with that fuzzy slide. There we go. You can also text your response to 37696, I think it is. Text MMH to add your keyword or phrase with an underscore. 37607. There we go. Thank you. Collaboration is up there. I'm going to add my word verbally. Payment incentives, which we're going to talk about at the next panel, or one of the next panels. Postpartum Medicaid extension. We know what that means, and probably the person adding that is thinking about implementation. Just because there's coverage doesn't mean that the services are being delivered. What does that look like? Again, reimbursement and health plans and Medicaid agencies explaining what care should look like in the postpartum period, maternity care in particular. Months, payment incentives, great. We'll keep those words coming. I see overhaul, which is interesting. Quality management, really great to see. Access, just because we have the benefit doesn't mean we have access to services. Keep those words coming. We're going to drop that image along with illustrations from today's session in the photos folder in the Whova app. So take a look